Understanding tPA. Why the rush for acute stroke treatment? Have you ever wondered why time is so critical when it comes to treating a stroke? The answer lies in a treatment called tissue plasminogen activator, or tPA. This medication is the primary thrombolytic therapy used for acute ischemic strokes, which occur when a blood clot blocks blood flow to the brain. The urgency in administering tPA is due to its time-sensitive effectiveness. It can significantly improve outcomes when given as soon as possible, ideally within 4.5 hours from the onset of stroke symptoms. The sooner it is administered, the better the chances of recovery. When a stroke occurs, the blockage of blood flow leads to ischemia, which can cause irreversible brain damage. tPA works by converting plasminogen into plasmin, an enzyme that breaks down the fibrin clots. This process helps restore blood flow to areas of the brain that are at risk but not yet permanently damaged. By doing so, tPA can save brain tissue, reduce neurological deficits, and enhance recovery chances. The rush for acute stroke treatment is crucial because brain cells begin to die within minutes after a stroke. The volume of salvageable brain tissue decreases rapidly over time. Clinical guidelines stress that every minute counts. Delays in treatment can reduce the likelihood of a good outcome and increase the risk of permanent disability. The time window for administering tPA is narrow. The Food and Drug Administration has approved it for use within 3 hours of symptom onset, with some patients eligible for treatment up to 4.5 hours based on clinical trials. However, beyond this window, the risks of treatment, such as increased bleeding, may outweigh the benefits. Before administering tPA, healthcare providers must carefully evaluate patients to rule out contraindications like active bleeding or recent surgery. Imaging, typically a computed tomography scan, is essential to ensure there is no intracranial hemorrhage before giving tPA. The recommended dose of alteplase, the specific form of tPA, is 0.9 milligrams per kilogram of body weight, with a maximum dose of 90 milligrams. 10% of this dose is given as an initial intravenous bolus, and the remainder is infused over 60 minutes. Close monitoring is necessary during and after the administration to detect any complications, such as bleeding. In cases of large vessel occlusion, mechanical thrombectomy may be performed alongside or after tPA treatment to further improve outcomes, especially if done within 6 hours of stroke onset. After receiving tPA, patients requiring intensive monitoring in specialized settings, such as intensive care units or neuroscience units, to manage their blood pressure and neurological status, and to prevent complications. In summary, the rush to administer tPA in cases of acute ischemic stroke is driven by the critical need for early clot dissolution to restore blood flow to the brain. This minimizes irreversible damage and enhances functional recovery. Delays can reduce the treatment's effectiveness and increase risks, making rapid assessment and decision-making essential in stroke care. Always consult healthcare professionals for personalized medical advice and treatment options.